Like many of you in this audience today, I have a fair number of credentials. I've got a bunch of letters after my name, I've had some fancy jobs, and I think by most objective measures for a person at my stage of life, I would probably be considered successful. But I'm also, from time to time, a failure. Now, when I say failure, I don't just mean that I sometimes stoop to bribing my 3-year-old with ice cream to try to get her to go to bed without a fight, although that's also true. I'm talking about big failure as a physician, as a health policy advocate, as a citizen who really cares about trying to improve the health of our community. One of the most memorable failures of my career so far as a clinician took place when I was about 3 years into practice as a family physician. A colleague physician who was not my patient called and asked if she could come and see me on a one-time basis about some back pain that she had been experiencing. She wanted a prescription for some anti-inflammatories and a referral to a physiotherapist. I saw her over my lunch hour. I took a detailed history. I did a thorough physical examination, and I determined that she was suffering from what's known as mechanical low back pain, which is another word for you put your back out. So I gave her the script for anti-inflammatories and referred her to physio, and I sent her on her way. 48 hours later, she was in an emergency department in Florida. She had a metastatic tumor on her spine. I had just examined her, and I'd missed it. Doctors hate to fail. Partly it's because we mostly choose medicine out of a desire to help people and to heal. And so it's really difficult to grapple with the reality that sometimes what we do harms our patients. But it's also because most of us who enter medicine are real type A personalities, driven to success. You know, we're overachievers, and we live in a world of straight A's. F is not in the alphabet. When you add to that the admission of failure can put you in a vulnerable spot as relates to malpractice and medical legal liability, wrestling with failure as a clinician is a difficult thing to do. But slowly, 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 medical culture is shifting away from the days when we used to try to sweep failure under the carpet towards a time when we'll be able to really learn collectively from our failures. Listen, I have been over the case I just described to you 1,000 times. First on my own, searching my soul to try to understand how I could make a mistake like that, then with close colleagues and with the patient herself. But perhaps more importantly, I use it now as a teaching case with the residents in my clinic. And several times I have brought it to my broader practice group when we get together to reflect together on difficult cases, either clinically or ethically, and try to learn from the mistakes that we make. We use work by thinkers such as Dr. Jerome Groopman from Harvard, who wrote a great book called How Doctors Think, to try to guide our conversations about our failures. Dr. Groopman would probably tell you that in the case I've just described, there were a few factors at play. The first was the fact that my patient was herself a physician, and probably in denial about some of the symptoms that she was experiencing. So that when she told me her story, she was subconsciously cherry-picking those elements of her experience to fit with the benign illness that she wanted to have rather than the neoplastic one that she actually had. But then there was my own cognitive error, which was that I latched on to what seemed to be the most likely scenario, and I probably physically didn't see those elements of the puzzle that didn't fit with the story that I had built for myself. This is a phenomenon called anchoring, and it's well documented in the psychology literature, including by Nobel Prize laureates Dr. Danielle Martin and Amos Tversky. Having intellectual frameworks like that you can use to think about how you fail and how you make mistakes, and then having regular, routine ways to reflect collectively and learn collectively from failure is increasingly becoming routine in day-to-day medical practice. And I think we would all agree that's a good thing. But moving from the individual level to the organizational level, we're also beginning to see signs that our institutions want to do more than just run away from our failures. There's a movement towards publicizing failure as an attempt to try to drive improvements in the healthcare system in our institutions, and particularly our hospitals. It's not uncommon now to see our hospitals in Canada publicizing on their websites their hospital infection rates, their surgical complication rates, and departments competing against each other to achieve the highest rates of compliance with hand washing standards, for example. The notion of organizational learning and root cause analysis, where failures are not seen as opportunities to shame and blame individual providers, but rather learning moments where you try to build systems to protect patients from failure, is increasingly commonplace. All this public reporting is not just about transparency and accountability. It's about driving change and driving quality improvement. And so we do see it happening to some degree on the practice level and at the hospital or institutional level. But the real work of learning from failure in healthcare has yet to be done. And that's at the level above what we've just been discussing. It's at the system level. It's where policy decisions get made and healthcare systems get designed such that we're not talking about just affecting the health of an individual, but an entire population. And that's where the conversation gets really hard, because to think about really learning from failure and embracing failure at the healthcare system level, we need a total culture change, not just at the front lines of healthcare, but in politics, in government, in the media, and among the broader public. So why should we care about learning from failure in healthcare systems in Canada today? Well, in part, I think it's because we all know in our hearts that there are places where our healthcare system has ossified and is failing to meet the needs of our communities and our citizens. The converging currents of an aging population, a desire to move care out of institutions and hospitals and into the community, the push and the drive to try to curb healthcare system costs are a burning platform that we're standing on, and that tells us that there's a need to think about new and innovative ways to deliver healthcare services that we've never done before. And if we're being sufficiently innovative, some of those are going to fail. As any entrepreneur will tell you, innovation is a risky business. We all know the statistic that says that 50% of startups fail in their first year. And a recent blog post by a venture capitalist from the US suggested that that number has increased by an additional 40% since the 2007 economic crisis in the US. He goes so far as to say that entrepreneurs should include the failure option in their business plan. And in the world of global development and aid, the notion of 100% success is widely viewed as problematic, which is hard when you're applying for funding, right? But the idea in global development that gets talked about is if you've got a 100% success rate, you're either picking problems that are too easy to solve or you're lying about your results. So what does that mean? It means that when we try to think about healthcare system innovation, we need to begin to understand that failure is the flip side of innovation. And if we're actually going to make headway in dealing with the healthcare system problems of the 21st century, we're going to have to be unafraid to innovate and to fail. Now, the reality is that in Canada, to be honest with you, we're not even yet that good at learning from our successes. Across the country, there are little pockets of innovation where we see amazing healthcare system work going on, where policymakers and communities are really taking risks and making a headway on difficult healthcare system problems such as wait times, cost increases, working to keep people well in the community, reducing hospital admissions and emergency department visits. Amazing programs, pockets of real stellar work. But we haven't yet figured out the magic bullet for how to scale those successes up so that every Canadian has access to them. The result is that when you get sick, whether or not you get access to the best possible care for the problem that you have may depend less on whether or not someone's figured out what the best possible care is, and more on whether that someone happens to live in your community. Like, obviously, this is a problem. Obviously, we all want a healthcare system that is continuously learning and adapting, changing based not on what we hope works or what sounds good, but on what we know works and on what we know doesn't. But if we're going to have that kind of healthcare system, it means that we are going to have a systematic approach to evaluating new programs and new delivery models of care, and we're going to have the guts, the courage to stand behind those evaluations, all of us together, when it turns out that they don't work. I think we can learn a lot from our colleagues in other fields on this. In business, the notion of failing fast and failing forward, there's lots of TED Talks about that, has become increasingly commonplace. And actually, there was an entire issue of the Harvard Business Review just on that topic a couple of years ago. And I mentioned the world of global development. Every year, Engineers Without Borders Canada, in addition to publicizing its successes, publishes an annual failure report. These reports go further than just acknowledging that some of their development projects failed. They celebrate failure. Why? Because Engineers Without Borders understands that in order to be a high-performing innovation organization, you got to take risks. And when you take risks, some of your projects are going to fail. But trying to extract the learning from those failures and to disseminate and publicize them widely, not just keeping those lessons for yourself, but putting them out there for the whole of the development community to learn from, is courage. And I think that Engineers Without Borders is setting the bar for all of us in that regard. So what would a healthcare system look like that actually learned from failure? How would we construct such a thing? Well, I think one of the things that we would need to do is to begin to make the admission and discussion and reporting of failure routine. That is what the failure report does. It takes it out of the hands of a courageous individual or group and makes it part of the day-to-day of what it means to be in the healthcare business. The problem is, of course, that you can't do that one by one. We have to all sort of link arms and do it together, because otherwise the first organization to admit to failure or the first minister of health to stand up and say we spent all this money and it didn't work risks getting crucified in the media and in question period. Particularly in a publicly funded healthcare system where we rightly hold our politicians to account for the way that tax dollars get spent, too often the discussions of failure are left to the reports of auditors general or to the media, rather than being seen as opportunities for thoughtful self-reflection by policymakers and government. So by beginning to make the discussions of failure routine and doing it across the system, we can start to turn that problem around. But the second thing I think we need to do is to move out of the world we live in right now where we have a black and white approach to failure. If a project doesn't work, you either continue it because it sounds good and you can't bear to let it go, or you trash it completely. We see examples of continuing projects that don't really work in healthcare all the time, unfortunately. Take, for example, the whole system demonstrator project that took place in the UK. This was an amazing project, a telemedicine project where they were monitoring patients with complex chronic heart failure and other illnesses in their homes and trying to prevent them from being readmitted to hospital, trying to keep them stable in the community. And it sounded fantastic. Unfortunately, the evaluation showed it simply didn't work. They didn't get the outcomes they had hoped for. The response? Scale it up. 3 million patients now across the NHS will have access to whole system demonstrator. It's just too hard to let go of a project that sounds that great. On the other end of the spectrum, and closer to home here in Ontario, the Diabetes Registry was an example of a project that didn't work. Again, it sounded like a really good idea, an electronic repository where we would be able to track all patients living with diabetes in the province of Ontario to try to drive improvements in the quality of care that we give for diabetes, which is such a common illness in Ontario. But it turned out not to work. The data were too hard to get, the technology was obsolete, the systems didn't talk to each other, nobody could figure out how to use it. And instead of using that as an example and springboarding into something that would be more useful for policymakers and clinicians, we simply trashed the project altogether. This notion of living in a world of black and white where you either continue on course or you simply let a project go entirely, it's really tempting to do things that way, but you lose the opportunity for thoughtful reflection and adaptation that an innovative system has to have the capacity to do. So I think ultimately, these diabetes projects that we see taking place across the country, where we're starting up projects that at best, we might have an idea of what's worked in another community and build on it, but at worst, very often, we're starting a new project all over again without having any notion that somebody else has already tried this idea and it didn't work, is pretty problematic. In order to build the responsive, sustainable, equitable, publicly funded healthcare system that all Canadians want and deserve, we are going to have the courage not just to talk about failure, but to celebrate it. And I know that's a concept that may make some people uncomfortable, right? Can't we just learn from failure? Do we really have to celebrate failure? It seems a little much, particularly when lives are on the line, right? We're pouring public dollars into a project, and it turns out actually that patients' lives haven't been saved, or worse, lives have been lost as a result of this innovation. But unless we move to that language, unless we try to scale up our failures in the same way that we need to scale up our successes, we're not going to make any headway in building an innovative healthcare system. The quote I carry with me from the 2011 Engineers Without Borders Failure Report comes from a 17th century Japanese samurai poet. "My barn having burned down, I can now see the moon." We can do amazing things in Canadian healthcare. We can build innovative projects that will change the whole landscape of how we deliver services to our population. But sometimes we're going to set fire to the barn. It's up to all of us to make sure that when that happens, we keep our eyes on the moon. Thank you.